Hi, everybody. Welcome to this session of the CARE Winter Hematology Update. I'm John Curvilla, and I work at the Princess Margaret Cancer Center in Toronto. Today, we're going to be doing a panel covering some of the data that was presented by Dr. Alex Herrera about Hodgkin's lymphoma.
I'm David Hodgson. I also work at the Princess Margaret Cancer Center.
I'm Peter Anglin from the Stronach Cancer Center in Newmarket, Ontario.
All right, so with that, let's just get right into it. So Alex picked a few of the key highlights that he thought were important in practice informing in Hodgkin's lymphoma. And the first topic he presented was one that we all have some challenges with in the clinic, which is older patients with Hodgkin's lymphoma. And so he showed some longer term follow-up of a prospective study that looked at brentuximab vedotin based combinations as frontline therapy in older patients where you may not consider ABVD as a standard due to toxicity or comorbidity issues. So, maybe I'll just start there. What do you guys think about the landscape in terms of older Hodgkin's lymphoma and these types of studies and how they may influence practice for us?
John, I thought it was really relevant because the second peak of lymphoma involves older patients. I'd cite that the age group that he looked at, median age was 69 to sort of 78, 79. So it was a real age group of older patients. And the challenge we have, one is dose intensity. The second thing is bleomycin lung toxicity with this group of patients. And that relates to much less cure rates than younger populations. So it's an unmet need. It's a real challenge to treat. And I'm still struggling with how to manage these patients going forward.
I think the other challenge is how difficult it is to study these patients because older Hodgkin lymphoma patients are not common, and you do get some older patients who can tolerate, ABVD or maybe omission of bleo. So, what it means, for example, for the approval of these drugs for these indications is going to be a challenge going forward when the sample sizes are small.
Yeah, and so I think the other thing that comes up, people do these proof of concept studies. And so, John Freeberg had been involved in the initial publication of this a few years ago when it came into press. And so they published early data, which, looked promising in one regard, in that the response rates to brentuximab-based combination, whether that's with DTIC, which was one arm, whether it was with bendamustine, or even with nivolumab, which was added, are very active in terms of their effectiveness. They did see a toxicity signal with the bendamustine combination. And I think the main concern in the frontline setting, though, is not really about overall response. It's really, what is the progression-free survival like, and what are the later outcomes? Because we know traditionally we want to believe Hodgkin's is a very curable malignancy, as we all know. And so, the cautionary tale here might be, even though the response rates were pretty decent, the median progression-free survival was unfortunate and was poor in some of the groups, with only 10 months for BV mono, but got into the range that was kind of acceptable at around 3.5 to 4 years for the other combination arms. And so, what do you think of that? As clinicians who've looked after a lot of Hodgkin's patients over the years, what are you telling your older Hodgkin's patient that you may expect for progression-free survival? And maybe, specifically for you, David, when you're thinking about the trade-offs of frontline therapy and adding radiotherapy, clearly we have to approach these patients differently because it's not the same toxicity efficacy ratio that we think about in younger patients.
Yeah, that's absolutely correct. That the toxicity trade-offs, certainly as far as radiation therapy goes, are very different, where the risk of getting a radiation-related second malignancy is, almost inconsequential. And interestingly, to speak to Peter's point about the outcome, if you look at SEER data, being a patient over the age of 50 with Hodgkin lymphoma is like having a stage 3 colon cancer diagnosis, as far as outcome is concerned. So, this is not the readily curable Hodgkin lymphoma in a 25-year-old that we're used to thinking about. And so it's easy to, mistakenly just apply the same framework of thinking about cure and toxicity. And it just doesn't apply. The progression-free survival is much worse, actually, in my view, surprisingly worse. And aside from the bleomycin issue, which is a real thing, but for what I do, the radiation-related toxicities are not as much of a consideration.
And what did you think, Peter? Like when you looked at some of the toxicity data there, for a novel type regimen, how does this compare to what you think your own experience was doing the things we've done for a long time? Modifying ABVD, leaving out bleo, playing a bit with dose intensity. Did this seem better from a toxicity standpoint, or would you just say it's kind of a bit different and we're left to really struggle if this is going to move the bar in Canada in any meaningful way?
I don't want to underestimate bleomycin toxicity in older patients. And so I think it's a real concern when patients are over 70. I was struck, and it's not new to any of us that treat Hodgkin's lymphoma and use brentuximab, the neuropathy rate was so high, and it led to discontinuation of therapy in a substantive number of patients. That can be a problem. It's a problem in younger patients. It's a problem in older patients. So we have to, I'm not sure where I land on this, but I have to say, one of the summaries of that talk was that brentuximab is versus the doublets, which went, as you say, up to 4 years and not reached with the immunotherapy. So I think as a single agent, I'm not keen on it. As a doublet, I'm much more excited about it. I think we're going to have to learn how to use it. And then there's the whole issue of, will we get access if we can't see survival data in a real phase 3? So I think in terms of us getting our hands on it and using it, we're probably a ways away.
Yeah,
it'll be interesting to see the neuropathy data as it matures, right? As the second and third generation of brentuximab trials go forward and people are more attuned to measuring neuropathy, which is something that the clinical community, frankly, has not been doing very well. It'll be interesting to see how disabling this actually is for some patients.
We're using brentuximab in younger patients who've had platinum or been blasting already is a real challenge. We have to recognize this is in naive, generally chemo-naive patients, but they have neuropathy related to other issues, including age, diabetes, and other comorbidities. So again, it's a big challenge.
Yeah, I think it's a very good point that you've both raised. And Alex, I think in the interest of time, he ended up highlighting very briefly at the end of his presentation an abstract that I think is quite important, which was the 5-year follow-up of the Echelon-1 phase 3 trial, which again looked at BV in combination with AVD versus ABVD in a non-PET adapted approach. The good news in that story was that the 5-year follow-up does continue to show that approximately 7% benefit in terms of PFS at 5 years. And again, that's where we should have some comfort level at thinking that does represent an improvement in cure at 5 years. And, to David's point about the peripheral neuropathy, there were not any excessive toxicities that were seen between 3 to 4 to 5 years. So reassuring that there aren't late events, but there again were a proportion of people that did continue with grade 1 or potentially grade 2 peripheral neuropathy, though the majority of those had resolved by the time they got into 3 or 4 year follow-up. The other interesting thing that came out of that data, and I think David has published about this too, was they looked at fertility, and in young women that were eligible, it looked like fertility did not appear to be impaired, at least based on the ways that we can assess that in this type of cohort. So again, some safety, showing comfort with giving BV in the upfront setting. And again, as we think about how that data will apply, as it is Health Canada approved, it is coming, I think, to the provinces in terms of reimbursement in stage 3 and potentially stage 4 Hodgkin's lymphoma, potentially stage 3 with the data. I think it's an interesting time for these patients and yet another option for us.
Mm-hmm.
Now, Alex did spend a lot of time in the relapse refractory setting because that is where a fair amount of the activity has been in terms of developmental studies. And so, maybe as we get into this, we can talk about the theme, which was largely about integrating checkpoint inhibitors, whether that's nivolumab or pembrolizumab, as well as brentuximab vedotin, into the curative setting, whether that's as part of salvage therapy before transplants, whether that's as consolidation post-transplant. And again, a population that, Canada, we still have a well-established standard GDP. We're hoping to move on beyond that. And so CCTG will be testing a randomized trial comparing BV plus Pembro versus GDP. But I'm curious to see what you guys thought here. There were a number of different studies showing that there are some novel agents that look active in the curative setting. And tell me what you think.
John, I thought it was exciting. 2 cycles of GVD plus the pembrolizumab, 92%. The majority of patients had 2. I think they could either had 2 or 4 cycles before going to high dose therapy. But 92% response rate, where most patients got 2 cycles going into transplant, and the long-term data looked good. So exciting stuff. I mean, it's certainly better. John, what's the standard number that you quote patients when you're talking about a GDP induction, which, as you point out, has been generally the standard in Canada for salvage?
Yeah, so our data have shown with CT imaging that the response rate's about 70%. The thing that we had struggled with, I think, is really getting good data looking at PET response with GDP and Hodgkin's lymphoma. And, Dave can comment on this as well, but, my sense there is that the PET CR rate is a little more modest, and it's probably in the range of about 35% or so. And so in our practice, we've usually thought of this as a platform, right? We want to see response. A PR is good enough, but we're looking to do things beyond that, right? Whether in a higher risk patient, it will involve consolidative radiation. We have used some salvage radiation pre-transplant, as Dave can speak to. And in those patients, particularly not in a CR, now that we have funding for BV based on the Athera data post-transplant, a lot of them are now getting that as consolidation. So, that's reassuring, but I think to move the bar forward in Canada, you'd already made the comment, we're going to need better trials. We need randomized studies. And so, the trial we're going to be running in Canada is the only randomized trial that we know of.
John, that's a randomized trial of immunotherapy with chemo versus standard chemo induction alone.
Yeah, so it's pembro brentuximab versus GDP as the second line therapy leading into transplant. Yeah, with the goal that the PET CR rate to the novel regimen is going to be a lot better, which again, these data tend to show. So maybe I'll put that to you as well, Dave. Like, where do you see on the platform novel agents, kind of integrating, and do you think it's more likely to be helpful to us front end? Because Alex also showed an interesting data set combining BV plus nivolumab consolidation post-transplant, where I think traditionally we've kind of felt the best idea is to try and get into as good a remission pre-transplant and let the transplant do the consolidation. So thoughts?
Well, I guess the issue is whether or not the biology of, of these agents, makes it more amenable or more sensible to use it in an upfront setting as compared to a relapse or as a maintenance setting, right? So when you're using clearly cytotoxic agents and you are trying to go for, tumor kill, then maybe that's when it made sense to, as we used to say, the Kairos principle. But maybe when you're giving immunotherapy agents, maybe that's not really the way those things need to be given. Maybe you are actually just trying to keep this tumor in abeyance for as long as possible. The one thing that strikes me about this, and actually about the other talks, is I really think we're going to have to figure out an entirely new way of running clinical trials. Like the proliferation of these agents, and they are so exciting, and the pace at which they are coming is just not going to be amenable to testing them like one at a time, one sequentially at one drug every 4 years. Like we just are going to have to come up with a better way of evaluating these drugs than we currently are.
Yeah, I mean, I would totally agree with that. And the struggle too is that as, in countries like the US where they can do single arm trials, they look encouraging, they can make, informed switches about how they want to practice. But, our environment remains one where, we've traditionally needed better level evidence in better constructed trials. And so we're going to fall behind on the efficiency standpoint as well, fairly quickly if we haven't already. I totally agree. So Peter, anything else in this section switch out to you? Because then Alex also moved on to cover some new space about what do we do in the patients that have failed everything, which, unfortunately we all manage some of those patients in our practice as well.
John, just one question about the consolidation trial, just to cite, those are a high risk group of patients who are primary refractory or relapsed within a year or required a couple of salvages. But in that group, the number I see here, 19-month PFS, 92%. John, how does that compare to your historical standard of cares that we have done? Understanding we are using brentuximab afterwards as maintenance.
I mean, in all honesty, Peter, it's excellent, right? Like, so when the first few papers that I wrote with Michael that looked at outcomes in our patients, when the switch went away from mini-beam to GDP, still looked like we were hitting maybe 65% PFS in all comers. And so you can kind of see what's happened is, the emergence of CR is a more important biomarker now, particularly with PET, the integration of some novel therapies up front, hopefully some consistent biopsies, ensuring that you're getting the right patients and you're not bringing DLBCL or primary mediastinal into the mix. The use of consolidative strategies like radiation in these patients, as well as BV. I think all of these things have raised the bar that even in the highest risk population, just looking back at Alex's presentation, even in the highest risk patients, admittedly the follow-up's only a year and a half, but they're still at 80% PFS. And we know most of the events happen by 2 years. So it's an encouraging story. It's a lot of therapy, I think, once you look at all the agents, and it's kind of led people in the field to start to ask this question, does this look good enough? Can we lighten it up? Should we be maybe looking at non-transplant based second line approaches where we mix in some of this stuff, which I think would be a great place to go in a randomized trial one day.
We're certainly seeing more gently treated patients, a lot more radiation naive patients. It does raise that as a distinct possibility. It also, does create, for example, an issue that we've talked about a bit in the children's oncology group, is you have these radiation naive patients. Now, we never had to consider what was a rational approach to using radiotherapy in a relapse setting trial. Now, we know that the biology changes, that the relapse tumors have emergent properties that were not seen in the initial presentation that can respond to radiotherapy. How are we going to integrate that in some rational way, which 5 and 10 years ago was not really an issue in a relapse trial?
Yeah, I think those are excellent comments. And again, as we're seeing the therapies play out and how we're applying them and when differently, yeah, it really does behoove us to keep an eye on how that affects biology and what we can do later. So maybe in our last couple of minutes, we'll just close with those last 2 abstracts I think that Alex covered. One was looking at an older drug, so everolimus, an mTOR inhibitor that was evaluated by the group at the Mayo for relapse refractory Hodgkin's lymphoma. And so it remains an option, but very difficult to access in Canada. And I think the next drug that people are hanging their hopes on in the treatment of multiply relapsed Hodgkin's lymphoma is this drug, camidanlimab tesirine, or CAM-ET, which is a CD25 directed antibody drug conjugate, where we'd seen some very good phase 1b type data, and now have seen a phase 2 trial that is fully accrued. This is a drug that does have a bit of a reputation for a unique toxicity, as it depletes regulatory T cells. And so there have been a few cases of a Guillain-Barré-like syndrome associated with it. But I think what really stands out to all of us is the activity. So in patients that have had BV or either a checkpoint inhibitor, you can see the activity here is a response rate of better than 80%. And so I think the registrational trial is now fully accrued, but this appears to be the next drug that'll be coming. And so, maybe I'll put it to you, what do you think about this challenging group of patients? And what do you think about a drug with a response rate of 80%, where you might see a 5 to 6% chance of developing a significant neurologic toxicity, largely reversible, like Guillain-Barré?
Well, in multiply relapsed patients, you're between a rock and a hard place, particularly after you've exhausted immunotherapy. John, I just want to provide a very brief frame. I remember single agent vinblastine was all we had to salvage patients and maintain them for palliation. That was 20 years ago. So we have come a long, long way. It's very exciting.
Yeah, absolutely. Yeah. The challenge, of course, again, is, a high response rate. you just always have to be careful about rubbing your hands too enthusiastically about response rate data.
Yeah, I totally agree, Dave. And so, much like what we saw with the checkpoint inhibitors, very good early signal. The progression-free survival, I think, will be very important. Again, it's a registrational trial that'll have a decent number of patients in it. I think ultimately it'll be around 100, and hopefully we'll see, a good proportion, hopefully 75 to 80, remaining progression-free beyond 12 months. And then I think we have the sort of data that we'd all want to see with a drug that we can use in the patients that may be unfortunately progressing following checkpoint inhibitors in BV, as we still struggle with that. So any other final comments from you before we close down?
Yeah, just to say again, here, what have we discussed? Like 5 promising new agents. If we're going to need some guys with some artificial intelligence, to tell us how to test these in combination in some rational way, because if we do them one at a time, that's like 25 years worth of trials.
And then we're going to have to find a way to get the drugs and access.
Yeah, not to mention the approvals.
All right. Well, again, I think Alex did a great job presenting the data. He hit a lot of the highlights for us. I think it was a great panel. Thank you both. And again, thanks to the audience for joining us.
Thank you.
Thanks, John.
Thank you.